Greetings all. Today's topic is about goiter. My name is Tamer Elsherbiny. I'm an associate professor of endocrinology. I work in the endocrinology unit, internal medicine department, Alexandria Faculty of Medicine. We are going to deal today with the topic of goiter. The agenda of the presentation is going to deal with the definition of goiter, classification, causes of goiter, the pathogenesis, the management, and finally surgery as an option to treat goiters. So goiter has been depicted in history through art. As you can see here, this is a presentation of Cleopatra VII, and you can see this engraving representing what seems to be a goiter in this famous queen who lived between 70 before Christ to 30 before Christ. Right about the same time, in another continent in North America, this man figure was found. As you can see, this represents a man with signs of long-standing iodine deficiency in the form of head disproportionately larger than the body, with bent knees and a goiter. Our first item is to define goiter. So simply, goiter is any abnormal enlargement of the thyroid gland. It can be defined according to the weight or according to the volume of the thyroid gland. So a person is said to be or is said to have a goiter when the thyroid weight is over 20 to 25 grams. Or if we use the volume, a person is said to have a goiter if the volume of the thyroid is over 19 milliliters in females or 25 milliliters in males. Before going through, we have to go through the physiology or the normal anatomy of the thyroid gland. So the normal thyroid gland is located in the lower midfront of the neck, extending between C5 and T1 vertebrae. The normal volume or the normal size ranges from 40 to 60 millimeters in longitudinal diameter and 13 to 18 millimeters in anteroposterior diameter. The mean sonographic volume is about 7 to 10 milliliters, and the normal weight ranges from 9 to 21 grams. Starting with the classification, the first classification, which is very important for you as an examiner and as a practitioner, is the clinical classification. In 1960, the WHO defined goiter as a thyroid with a lateral lobe that has a volume greater than the terminal phalanges of the thumbs of the person examined. And then in 1994, the WHO reclassified goiter into defining goiter as any enlarged or bulbable thyroid as a goiter. Accordingly, we actually have two clinical classifications for a goiter. According to the older one, the 1961, any thyroid that is not bulbable is classified as grade 0. Any bulbable thyroid with lobes smaller than or equal to the terminal phalanx of the examined individual is also classified as grade 0. Only those who have a bulbable lobes larger than the terminal phalanx of the examined individual would have grade 1A, and if the thyroid is visible with neck extended, this would be classified as having a goiter grade 1B. If the person has a goiter that is visible with head in normal position, this would be classified as grade 2. Or if a person has a goiter that is visible at distance, this would be classified as grade 3. This was the old classification. If we look at the newer classification, the 1994 WHO classification, then it would be a totally different matter. So all non-bulbable thyroids are classified as grade 0, no goiter. Any bulbable thyroid, whether this is less than or equal or greater than the examined individual thumb, this would be classified as grade 1, including those who have a goiter that is visible with neck extended. A person with goiter that is visible with head in normal position or at a distance would be classified as grade 2. Another way to classify goiter is into classifying it according to the position. So we have cervical goiters, which are completely situated in the neck. We have intrathoracic goiter, which are completely situated inside the thorax. And then we have what we call the retrosternal goiter, which has a part in the cervix and part retrosternal. And then we have a classification of what we call the retrosternal goiter according to the intrathoracic extension of the intrathoracic part. So we have grade 1, with the intrathoracic part reaching above the aortic arch. This means above T4. The grade 2 is intrathoracic extension reaching the aortic arch to the pericardium, and grade 3 is those with intrathoracic extension reaching below the right atrium. We can classify goiter according to the function into toxic goiter or non-toxic goiter. And for non-toxic goiters, this may be associated with either euthyroidism or hypothyroidism. Then we have the morphological classification into either having a diffuse goiter or a nodular goiter, and for a nodular goiter, it may be either solitary nodular or multinodular goiter. One last way to classify goiter is based on pathophysiology, what causes the enlargement of the thyroid. So we have this TSH dependent or TSH independent. Examples of causes that would lead to a goiter through TSH would be dyshormonogenesis, iodine deficiency, intake of goitrogens, or dealing with antithyroid drugs. While examples for TSH independent goiters, it would be Graves' disease, which is mediated by the presence of TSH receptor antibodies, or other intrinsic thyroid disorders like thyroid tumors, infections, or inflammation. And then we go to etiological classification, or in other words, what causes goiter? So before handling with the first cause of goiter, which is dyshormonogenesis, we have to go through the steps of synthesis of thyroid hormones. So here you can see the first step. The first step is iodide trapping, and iodide trapping is mediated through sodium iodide symporter. And then it goes into the follicular cells, and then we go to the what we call iodine efflux, the apical iodine efflux, which is mediated by a protein that's called bindrine. And then we go under the process of iodine oxidation. And by iodine oxidation, that is the transformation of two iodides into iodine. And for this step to be accomplished, we need the assistance or the help of the dual oxidase enzyme, which is also called the thyroid oxidase 2. That's why you would have two abbreviations for this enzyme. Dual oxidase 2 is abbreviated as DOX2, and thyroid oxidase 2 is abbreviated as THOX2. Then after having this oxidation or having an iodine, then we go into organification. Organification means incorporation of the iodine into thyroglobulin. After this organification, this would generate either monoiodotyrosine or diiodotyrosine, and then we go to the last step of thyroid hormone synthesis, which is coupling. And coupling would result in the formation of either triiodothyronine or tetraiodothyronine, and then, according to the metabolic need, this would be then internalized into the follicular cells and then released into the stream of the body, of the blood. Accordingly, if we have any enzymatic defect in any of these steps, this is going to generate what we call dyshormonogenesis. The most commonly affected would be the thyroperoxidase. However, affection of dual oxidase, affection of bindrine, or affection of sodium iodide symporter is going to induce this so-called dyshormonogenesis. So actually, dyshormonogenesis is a group of autosomal recessive disorders that result from enzymatic defect in one of the steps of thyroid hormone synthesis. The most common of which being thyroperoxidase. As I told you, it is more common in females. Most of the cases will present in the form of goiter and hypothyroidism as early as the neonatal period, and only in the Bendred syndrome that's goiter associated with stiffness. And going back to the art, in 1599, this statue was carved representing a goitrous Jew, presenting with a huge goiter and cretin features. So even cretinism has been represented in the art. The second important cause would be iodine deficiency. So actually 30% of the world population lives in an area where it's considered to be iodine deficient. Iodine deficiency is the most common cause of goiter worldwide. More than 30% of population having iodine deficiency would develop a goiter. The daily requirement of iodine ranges from 100 to 100 micrograms per day, and this requirement increases during pregnancy and lactation. actually, the first one who discovered iodine was Bernard Courtois in 1911. Lugol was the first one to associate iodine deficiency with a goiter, and David Marine was the first one to prove requirement of iodine for normal thyroid function, and also he is considered to be the father of salt iodization. So actually, salt iodization was first introduced in the United States in 1922 to prevent the occurrence of endemic goiter. Why specifically salt? Because salt is a universal foodstuff. It is inexpensive, it is easily available, and its intake is relatively daily constant. Approximately 120 countries, including the United States, the United Kingdom, Canada, and Egypt, has adopted mandatory iodization of all food salt. Again, another representation of goiter in history. Back in 1607, you can see this goitrous lady in this painting. She is clearly coming from a low-class society where iodine deficiency was common among poor people due to malnutrition. Other dietary factors would include the so-called goitrogens. So goitrogens is foodstuff that may lead to the occurrence of goiter. So the first example would be soy and millet. فول الصويا وحبوب الدخن. They contain what we call flavonoids, which impair thyroid peroxidase activity. And then another example would be cassava and lima beans. Lima beans, اللي هي الفاصوليا, they contain what we call cyanogenic glucosides, which compete for iodine uptake in the thyroid follicles. And then we have the so-called cruciferous vegetables. So cruciferous vegetables include cabbage, الكرنب, cauliflower, الكرنبيط, البروكلي, radish, اللي هو الفجل, whether this is white radish or red radish, الجرجير واللفت as well is considered to be cruciferous vegetables. They contain glucosinolates, which also compete with thyroidal iodine uptake. So this is actually a whole list of what we call goitrogens, including the ones that I have shown to you and other ones, including the seaweed. The seaweed is actually induces hypothyroidism or goiter through having an iodine excess, because actually iodine excess inhibits the release of thyroid hormones through what we call Wolff-Chaikoff effect. Also, other aspects of malnutrition may lead to goiter, like vitamin A deficiency leading to increased TSH stimulation, iron deficiency, which reduces heme-dependent thyroid peroxidase activity, and finally selenium, because selenium is required for effective removal of oxygen species or reactive oxygen species. So in the absence of selenium, this would lead to accumulation of hydrogen peroxide, which is required for the synthesis or the oxidation and organification of iodine. The fourth cause of goiter would be drugs. The most famous examples would be lithium and imidazole. However, other rare causes include interferon alpha, which was used to treat chronic HCV back in a number of years, and also rifampicin, phenytoin, and phenobarbital are known to accelerate the clearance of levothyroxine or thyroxine from the circulation. Number 5, which is also a very important cause of goiter, is Hashimoto thyroiditis. So actually Hashimoto thyroiditis is the next most common cause of hypothyroidism after iodine deficiency. It affects females 7 times more likely compared to males, although there is a subset of patients which may remain clinically and biochemically euthyroid for the remainder of their life. Actually, it was Hikaru Hashimoto who first described this disease in 1912. He presented the first surgical series of cases of Hashimoto thyroiditis, which at the time he called stroma lymphomatosa. It was actually 20 years later when this same disease was redescribed in the Western world, and then they started to refer to this disease as Hashimoto thyroiditis, giving him credit for the first description of Hashimoto disease. And then we go for the Graves' disease. In Graves' disease, it is an autoimmune condition characterized by the presence of TSH receptor antibodies. It occurs more in females. Like all autoimmune diseases, it usually presents before the age of 30 years. The risk factors include high iodine intake, stress, and the use of certain drugs like interferon alpha and alemtuzumab. The clinical stigmata include hyperthyroidism, a diffuse goiter, the presence of orbitopathy, and rarely the presence of dermopathy. Again, it was Robert James Graves in 1935 to describe the first case of Graves. He described a case of a goiter with exophthalmos, and actually it was more or less 50 years later when they started to associate the discovery of this disease with Graves, and that's why it was named after Robert James Graves. And then we have the multinodular goiter, which may be euthyroid or toxic. However, multinodular goiter with thyrotoxicosis is also known as Bloomer disease. So toxic multinodular goiter comes from an activating somatic mutation of the TSH receptor gene, which leads to hyperplasia of thyroid follicular cells independent from the TSH regulation. Incidence of thyrotoxicosis on top of a multinodular goiter is related to the duration of multinodular goiter. That is why it is more common in elderly, because it requires long time to issue. Also, we have the so-called thyroid adenoma, which is classified histologically into either follicular or papillary. Adenomas may be also hyperfunctioning, and in this way it would be called toxic adenoma. Whether it is a uninodular or a multinodular goiter, it may come toxic, as I have shown you, or it may come without hyperfunctioning. So a goiter, due to the accumulation of colloid without having hyperfunctioning, is called colloid goiter. So a thyroid enlargement without accompanying disturbance in thyroid function is called colloid goiter. It has many other names, including the endemic goiter, simple goiter, non-toxic uninodular or non-toxic multinodular goiter, or simply nodular hyperplasia. The 10th cause of goiter is thyroid malignancies, which can be classified as either papillary, follicular, medullary, anaplastic, or thyroid lymphoma, with the papillary being the most common and thyroid lymphoma being the rarest. We have the so-called the Marine-Linhart disease, which is a combination of functioning thyroid nodules associated with Graves' disease. And actually it can be reclassified into subtypes. Type 1, where you have one hyperfunctioning nodule along with Graves. We have the type 2, where you have multiple hyperfunctioning nodules along with Graves. And we have the type 3, where you have a number of hyperfunctioning and hypofunctioning nodules on a background of Graves. The thyroiditis is another cause of goiter, the most famous examples of which would be subacute thyroiditis and renal thyroiditis. The subacute thyroiditis is a non-suppurative type of thyroiditis caused by viral infection. It is characterized by neck pain and tenderness associated with constitutional manifestations like fever, fatigue, and myalgia. Usually it goes into hyperthyroidism that is followed by euthyroidism. While renal thyroiditis is actually a rare condition of unknown etiology that affects middle-aged women, where thyroid follicles are replaced by fibrous tissue. Initially it presents with a goiter, and later it presents with hypothyroidism. Infiltrative thyroid disorders is another example of goiter, examples of which would be amyloidosis, sarcoidosis, and histiocytosis. So what is the pathogenesis of having an enlarged thyroid, which is called goiter? The first and most important would be chronic stimulation of follicular cells by a higher than normal TSH levels, examples of which would be iodine deficiency and Hashimoto disease. The second factor would be genetic factors like mutations affecting the TSH receptor gene, the thyroid oxidase 2, the THOX2, which is also known, as I told you, as the dual oxidase 2, or genetic mutations affecting the thyroid peroxidase enzyme. Naturally occurring goitogens, I have shown you a number of examples for this, which either impair the thyroid peroxidase activity or inhibit iodine thyroid uptake or inhibit the release of thyroid hormones. Finally, other forms of malnutrition which work only in the presence of iodine deficiency, like protein energy malnutrition or deficiency of iron, selenium, or vitamin E, can also share in the pathogenesis of goiter. So this graph would explain a little bit about the formation of a goiter. So it starts usually with iodine deficiency. Iodine deficiency directly leads to hyperplasia of the thyroid. through an increase in the TSH. So simply increase in the TSH would lead to proliferation or hyperplasia of the thyroid. Also, iodine deficiency may indirectly lead to the accumulation of hydrogen peroxide, which are considered to be free radicals. So the combination of iodine deficiency, TSH stimulation, the accumulation of free radicals on a background of genetic susceptibility, this is going to induce mutagenesis. So mutagenesis will lead to either two types of mutations. The first mutation is an activating mutation, where these cells acquire the ability or the autonomy to produce thyroid hormones independent from TSH stimulation, which are called hot nodules. And the other type of mutagenesis or mutations would be a dedifferentiation genetic mutations, which will lead to hypofunctioning thyroid nodules. So iodine deficiency, the TSH stimulation, the accumulation of free radicals on the background of genetic susceptibility is going to induce mutagenesis, which will lead to either hyperfunctioning nodules due to stimulation mutations or hypofunctioning nodules due to dedifferentiation mutations. Back to the art. So these are examples of goiters represented in works of art. Here you can see this example in 1556, another example in 1460, a third example in 1613, and a fourth example in the 17th century. Goiters actually can be very large, so you can see this example in 2020, where this patient has this pendulous goiter, and actually such patients would require a sling to help this patient to carry this very heavy goiters. And actually this is the most extreme example that you would find either in practice or in history. This was painted in 1951, and as you can see, this is a humongous goiter, which are called pendulous goiter. Going back to investigating a case presenting with a goiter. The first would be ordering thyroid function test, which may reveal either hyperthyroidism or hypothyroidism. For hyperthyroidism, it may be considered subclinical in the presence of suppressed TSH with normal free T3 and normal free T4. It may be considered overt in the presence of suppressed TSH, high free T3 and high free T4. And this may be present in patients with Graves' disease or toxic multinodular goiter or toxic adenoma. In hypothyroidism, it may be subclassified into subclinical with having high TSH with a normal free T4, or overt hypothyroidism having high TSH and low free T4, and this may be caused by iodine deficiency, Hashimoto thyroiditis, or deshormonogenesis. The second to order would be thyroid peroxidase antibodies. The presence of this antibody indicates the presence of autoimmune thyroid disease, and autoimmune thyroid disease is represented by Hashimoto thyroiditis, Graves' disease, silent thyroiditis, postpartum thyroiditis. All of these may present with positivity of thyroid peroxidase antibodies. The next to order would be thyroid ultrasound, and you should order ultrasound in the presence of these indications: palpable solitary nodule, palpable multinodular goiter, suspicion of a nodule in a patient with difficult to palpate neck, rapid growth of a goiter, thyroid asymmetry, heart consistency, or the presence of tenderness. So, how would we make use of the thyroid ultrasound? If you find a nodule, then you are going to look for signs of benignity or signs of malignancy. Starting with the first pattern, this would be the first pattern. This is a completely cystic nodule. A completely cystic nodule is considered to be a benign pattern. The next would be this so-called spongy form. So it looks like a sponge with more than 50% converted into cystic spaces, and this is considered to be a low suspicious presentation, or a very low suspicious presentation. And then we go into the echogenicity. So if we have hyper-echogenicity or iso-echogenicity, this would be considered to be a low-risk profile. So this is considered to be a low-risk profile. And then we have the high-risk profile. And for the high-risk profile, this includes nodules with hypoechogenicity or very hypoechogenicity. This is considered to be high risk. How about the very high risk? And so the very high risk comes for those who have vertical orientation rather than a horizontal orientation, those who have irregular borders, those who have microcalcifications, and finally, those who have extrathyroidal extensions. So starting from a benign profile, a very low risk, a low risk, a high risk, or a very high risk. And that's why after performing the ultrasound, you would classify the thyroid nodules into these classes. Benign presentations, which is the pure cyst, has a less than 1% chance of having malignancy. The very low, which is the spongy form, has less than 3% chance of having a malignancy. The low suspicion, which is the hyperechoic or the isoechoic, this has only 5 to 10% chance of having malignancy. The intermediate or high, this is the hypoechoic. This has a chance of 10 to 20%, while those who are considered to be very high or high suspicion, this has a risk of 70 to 90% of having malignancy, including the microcalcification, the taller than wide orientation, having involvement of the lymph nodes, having an irregular margin, or extrathyroidal extension. And according to classifying the thyroid nodule into these categories of risk, we are going to perform fine needle aspiration cytology in certain indications. So the benign pattern does not require fine needle aspiration cytology. For very low suspicion, this requires fine needle aspiration cytology only if it exceeds 2 centimeters in diameter. For the low suspicion, only if it exceeds 1.5 centimeters. For the intermediate suspicion, only if it exceeds 1 centimeter. And for the high suspicion, only if it exceeds 1 centimeter. Accordingly, the next step would be fine needle aspiration cytology. So, according to the results of the fine needle aspiration cytology, we would have either one of three. Those who are classified as benign, and this has less than 3% chance of having malignancy, and this would require only clinical follow-up. Those who are considered as having suspicion for malignancy or malignancy, this has a malignancy risk that ranges from 50% to 99%. And these patients should be sent for total thyroidectomy. While those who are considered to be indeterminate or moderate suspicion, those have a risk of malignancy that ranges from 10 to 40%, which may require either repetition of fine needle aspiration cytology or molecular testing or going for lobectomy. The technetium scan or radioactive iodine uptake is not considered to be a routine investigation in patients presenting with a goiter. In those who present with hyperthyroidism, it is useful to differentiate between Graves' disease, thyroiditis, or toxic adenoma. When the fine needle aspiration cytology report is equivocal, a hot nodule in scintigraphy suggests benign, while a cold nodule may suggest a malignant lesion. The CT of the neck is only resorted to in those who have a large cervical goiters or those with a suspicion of substernal goiters. While for the treatment, we first have the medical treatment in the form of levothyroxine in those who present with overt or subclinical hypothyroidism. We have the antithyroid drugs in those who present with hyperfunction, like those who have Graves' disease or toxic multinodular goiter, usually a toxic adenoma. We resort to surgery. The radioactive iodine ablation, usually the radioactive iodine ablation is taken in the form of capsule, and actually you can see this radioiodine capsule besides a tablet of Panadol. Okay, so you can see that this is very easy to administer. However, you should know that the radioactive iodine ablation takes from 6 to 18 weeks to achieve the thyroid ablation. And then we go for surgery. We may go for surgery in certain indications. So if we have a nodule, and this nodule was subjected to fine needle aspiration cytology, so in these instances we may go for surgery. So if it is classified as intermediate risk of malignancy, we may go for lobectomy. And in the procedure of lobectomy, you either remove a whole loop of the thyroid, or in some cases you may go also for esmiocyctomy. If the patient is classified as suspicion of malignancy or malignancy, in this case we go for total thyroidectomy, and in total thyroidectomy we completely remove the thyroid. If you have a patient with toxic adenoma, it is recommended by the American Thyroid Association that you should go for an ipsilateral lobectomy. If you have a patient with toxic multinodular goiter, again it is recommended by the American Thyroid Association to go for total thyroidectomy. Both are classified as strong recommendation. However, we should have some detailed description of the role of surgery in a patient with Graves' disease. Because as you know, Graves' disease is the most common cause of hyperthyroidism, representing almost 80% of all cases presenting with hyperthyroidism. So what I'm going to show you are recommendations coming from the American Thyroid Association and European Thyroid Association. So what does the current guidelines say? The current guidelines does not recommend thyroidectomy as the first line of treatment. The first line of treatment should be anti-thyroid drugs. And you should go for surgery as a first-line treatment only in those who prefer this approach. So actually, thyroidectomy is considered to be a second or a third line after failure of a first anti-thyroid drugs course. What are the advantages of surgery in such a scenario? It achieves rapid control of hyperthyroidism with no recurrence of hyperthyroidism, no detrimental effect on the course of Graves' ophthalmopathy, because radioactive iodine ablation may exacerbate or cause new onset ophthalmopathy, and definitely it has no radiation risk. However, the disadvantages are related to the post-operative complications like post-operative hypoparathyroidism and the risk of having recurrent nerve palsy. It has a high cost, it requires hospitalization, it leads to permanent scar. However, permanent hypothyroidism is not considered to be a complication rather than a sequel. So what are the indications to consider surgery in a patient who is presenting with Graves'? First, having coexisting hyperparathyroidism requiring surgery. Second, the malignancy suspicion. So if you have thyroid malignancy that is documented or highly suspected, or if you have a large thyroid nodule, especially those who are greater than 4 centimeters, or those who are non-functioning or hypofunctioning in technetium scan. The presence of compression, the symptomatic compression, which is usually occurs in those who have a large goiters greater than 80 grams in weight. The presence of Graves' orpitopathy with moderate to severe active Graves' ophthalmopathy, because in such cases radioactive iodine ablation would be contraindicated. Intolerance to antithyroid drugs. When a patient suffers from major adverse reactions of antithyroid drugs, what do we consider to be the major adverse reactions of antithyroid drugs? The most important of which would be a granulocytosis, and also we have drug-induced lupus, and also we have the ANCA-associated vasculitis. Having a plan for pregnancy in a short period, women planning to have pregnancy in less than 6 months, this is much better because at this situation, radioactive iodine ablation would be contraindicated. In childhood, thyroidectomy is the primary definitive therapy because exposure of children to radioactive iodine ablation in such a young age may increase the risk of having future malignancy. What are the contraindications of surgery in patients with Graves' disease? Number one, having substantial comorbidity like cardiopulmonary disease or end-stage cancer or debilitating disorders. Lack of access to a high-volume thyroid surgeon, because actually the complications of surgery is directly related to the experience of the surgeon. Patients who are previously operated or irradiated, because in such conditions, the surgeon would find extensive fibrosis, and so most probably it will not be a successful surgery. Pregnancy is a relative contraindication. It should only be used in circumstances where rapid control of hyperthyroidism is required and antithyroid medications cannot be used. Thyroid surgery during pregnancy has a higher rate of surgical complications like hypoparathyroidism and recurrent laryngeal nerve injury. If you are going to operate during pregnancy, you should avoid the first trimester and the third trimester. You should avoid the first trimester because of the teratogenic effect of anesthetic agents and the risk of fetal loss. And you should avoid this in the third trimester due to the risk of preterm labor. So optimally, if thyroidectomy is planned during pregnancy, it should be in the second trimester. However, this does not come without a price, because operating during pregnancy, even in the second trimester, is associated with 4.5 to 5.5 risk of preterm labor. Old age is considered to be a relative contraindication for surgery, especially in those who have atrial fibrillation, heart failure, or ischemic heart disease. What technique should be adopted? Total thyroidectomy is recommended by the European Thyroid Association if you choose the surgical treatment in patients with Graves' disease. Even in children, it is going to be total or near total thyroidectomy as recommended by the American Thyroid Association. So finally, to minimize the risk of complications of surgery, you have to go through 5 steps. The first step, surgery should be performed by a skilled high volume surgeon to minimize the risk of complications, including hypoparathyroidism, the laryngeal nerve palsy, wound infection, or hemorrhage. And this is actually a recommendation, a strong recommendation by the American Thyroid Association. The second step, that hyperthyroidism should be adequately controlled prior to surgery to minimize the risk of intra or post-operative exacerbation of thyrotoxicosis, and actually this is a recommendation by the European Thyroid Association. The third step should be vitamin D deficiency correction to reduce the risk of post-operative hypocalcemia, and actually this is also a recommendation by the European Thyroid Association. The fourth step is to use saturated solution of potassium iodide, SSKI. This is helpful in immediate preoperative period because it decreases the release of thyroid hormones. It should be used 10 days immediate preoperative. This is going to decrease the vascularity and intraoperative blood loss. And again, this is a recommendation by the European Thyroid Association. It should be used 3 times daily, mixed with water or juice, 10 days before the surgery, either using Lugol's solution or the saturated potassium iodide solution. The last step, if you are in a hurry for thyroidectomy and it must be performed before adequate control of hyperthyroidism, so you have to give your patient 4 measures. You have to give your patient antithyroid drugs, you have to give your patient beta blockers, you have to give your patient glucocorticoids, and you have to give your patient saturated solution of potassium iodide. This may be helpful, and this is again a recommendation by the American Thyroid Association. So the key messages of the presentation is: most common causes of goiter are iodine deficiency and Hashimoto thyroiditis. Other causes include Graves' disease, tumors, inflammation, and infiltration. The pathogenesis includes TSH stimulation, the most important genetic factors, the intake of goitrogens, and malnutrition. Investigating a goiter requires thyroid function testing, thyroid autoantibodies, the ultrasound, the fine needle aspiration cytology, and a thyroid scan. The management includes either medical treatment, radioactive iodine ablation, or surgery. Regarding the part with the surgery, patient preference, desire for pregnancy, compressive symptoms, malignancy or suspicion of malignancy, active Graves or petopathy are important indications for surgery, while also the patient preference, old age, comorbidity are important contraindications for surgery. If you are going to operate on a patient with Graves, near total or total thyroidectomy is the procedure of choice. A high volume surgeon is a must, and you have to remember the conditions that you should adopt for a successful surgery: to achieve euthyroidism, to replete vitamin D, and to use potassium iodides in preoperative preparation. Thank you for listening. I hope this was informative, and I hope to see you in your exams, inshallah, and you should accomplish a very high performance, inshallah. Thank you very much.